everyone, and thanks a lot to the organizing committee for today. It wouldn't have happened without their help. So I'm not gonna delay you anymore. We're just gonna, without any further ado, jump straight into the talk. I've got nothing to declare in terms of conflict of interest. And actually, I set a challenge to myself today. I thought I'm going to talk to you about a cardiology talk that includes PCI and STEMIs without showing you a single ECG. So let's see if I can manage to get that done or not. Can you all see the QR code? If you can, let's just scan it so we can have some interaction during the talk, if that's okay. There'll be more QR codes coming, so if you couldn't catch that one, feel free to wait. Okay, here's our first talk, our first case. So we're going to start with a 71-year-old male patient presented to you in ED with a cardiac sounding chest pain and shortness of breath. You're in resus now. You found this patient in pulmonary edema with low blood pressure, intermittent runs of ventricular tachycardia, and you've got your troponin back and it is raised. So you were thinking that this patient has got non-STEMI because the ECG that you've done for this patient showed no signs of STEMI. So in summary, old chap coming to you with a cardiac sounding chest pain, pulmonary edema, low blood pressure, so that's cardiogenic shock, and intermittent runs of ventricular tachycardia, and you're thinking non-STEMI. Question to you now is, would this patient qualify for immediate primary PCI in your local hospital? Please answer by yes or no. Don't worry, the answer will appear as anonymized, so feel free to put your opinion and no one will know. So I'll give you a few seconds and let's see what you think. And I want you to be honest with your answers. Any more responses? Okay, let's see what you guys think. So the majority are with no. So you don't really think that this patient would qualify for primary PCI in your local hospital. So that's really interesting because we've got candidates from about 25 different countries. So it's really interesting to see this. This is kind of a global impression. Okay, let's talk about this then. So let's talk about PCI for non-STEMIs. So what I'm going to be referring to in this talk is the 2020 European Society of Cardiology guidelines that was actually published in 2021. And it's talking about ACS in patients presenting without persistent ST elevation. So let's see what they suggest. What they did was they risk stratified the patients to two groups. The very high risk group, they straight away get an immediate PCI. And the high risk group, and those ones, they get an early PCI, so within less than 24 hours. So two groups, very high risk, they go straight to the cath lab, and high risk, they go to the cath lab within 24 hours, depending upon the cardiologist's decision. So these are the criteria. So let's have a look at the very high risk criteria. Look at this. They said here that an immediate invasive strategy within less than 2 hours is recommended for patients with at least one of the following. Our patient has been hemodynamically unstable in a cardiogenic shock. Our patient has had life-threatening ventricular tachycardias. Our patient has had heart failure that we thought is secondary to non-STEMI. So actually, our patient ticked 3 out of these boxes that would qualify this patient to be diverted straight to the cath lab within less than 2 hours. And the evidence for this is a class 1C evidence. So that's a really high level of evidence to support this decision. So how about the American College of Cardiology guidelines? The 2020 guidelines, they just followed the European one. They said that an immediate invasive angio is required if your patient is hemodynamically unstable or having unstable arrhythmias or having acute heart failure or persistent chest pain. So basically, if your patient is hemodynamically unstable or electrically unstable or with persistent chest pain, this would qualify the patient for immediate invasive angio. Those are the patients that are without an ST elevation associated with their chest pain. So that's coming from the American studies. So let's go back to our patient and revisit the story. Our patient was a 71-year-old, presented to ED with a cardiac sounding chest pain and shortness of breath. Our patient has had pulmonary edema, low blood pressure, intermittent runs of VT with raised troponin. So that made you think non-STEMI because the 12-lead ECG was done and showed no ST elevation. The question is, would you immediately activate this patient for PCI? Would you activate the cath lab? The answer should be yes. That is following the European Society of Cardiology guidelines and American Heart Association guidelines. And that was our first case. Let's move on to our second case, 2 out of 3. So this one is going to be about a 64-year-old male patient presented to ED following an unexplained VF cardiac arrest. So this patient has had an out-of-hospital ventricular fibrillation cardiac arrest. You've managed to get the patient back, and now you've got ROSC. The patient now is hemodynamically stable with normal blood pressure. You've done a 12-lead ECG for this patient, and the ECG showed no signs of STEMI. So you've got a post-unexplained VF cardiac arrest coming to you with an ECG that is showing no signs of STEMI and hemodynamic stability. The question to you now is, would this patient qualify for immediate PCI activation in your local hospital? Let's see what you guys think. Okay, I'll give you a few more seconds to try to guess what the answer is going to be. Any more? Okay, let's see. So we're getting towards nearly 50-50, but again, the majority is with no, okay? Unless you people change your mind. So it's almost 50-50. Okay, so let's see what the answer would be. Let's talk about PCI post-VF cardiac arrest. So where do we stand these days with the evidence? Well, it's 2 groups of patients. So basically, if we're talking about post-cardiac arrest plus STEMI in the ECG, that's easy. We're done. This is straight to the cath lab. No one is going to argue about this. No discussions needed. Post-cardiac arrest plus STEMI, they go straight to the cath lab. The question is about post-cardiac arrest without a STEMI. Back in 2014, the recommendations from the American Heart Association regarding post-VF cardiac arrest was crystal clear. They should all go immediately to the cath lab. So here is the document that talked about this back in 2014. And they said clearly here that immediate catheterization is now indicated for patients who are post-ventricular fibrillation cardiac arrest, even in absence of ST elevation on the ECG. So there is no doubt about it, it's crystal clear. But over the next few years, from 2014 till today, the evidence started growing. And in 2019, the COACT trial came out with a bit of a surprise. So COACT trial stands for coronary angio after cardiac arrest without ST elevation. It was a nicely designed trial that was published in 2019. Multi-center trial, randomly assigned over 500 patients with cardiac arrest without signs of STEMI. So they've split them into 2 arms. The first arm received immediate coronary angio, and the other arm received delayed coronary angio. The primary outcome for this was the survival at 90 days, and they also had many secondary endpoints that they've studied. The conclusion was very surprising to everyone. The strategy of immediate angio was not found to be better than the delayed angio. So keeping patients without taking them to the cath lab for up to 24 hours did not result in an overall change in survival. And actually, even the secondary outcomes, when they studied them, they found no significant difference between the 2 groups. So this was quite shocking to everyone who was following this trial, including myself. So based upon the change in the evidence, the 2020 European Society of Cardiology guidelines that we've just visited, we're going to revisit now. And they talked about this. So again, we said that we're going to risk stratify our patients into 2 groups. The very high risk group, they get immediate angio. The high risk group, they get delayed angio. Look at this box, the high risk group, and look at this. So resuscitated cardiac arrest without ST elevation or cardiogenic shock, they come under the high-risk group, and the high-risk group, they get NG within 24 hours. So here is another part of the same guidelines of the ESC, and they talked here about delayed as opposed to immediate, and you should be considered in hemodynamically stable patients without ST elevation, successfully resuscitated after out of hospital cardiac arrest. The evidence here is in yellow. So actually, this is a class 2A evidence, which is still quite a high level of evidence. So if we go back to our patient, who was a 64-year-old male coming with unexplained VF cardiac arrest, you've managed to get ROSC, your patient is stable, and the ECG is not showing a STEMI. Would you activate the cath lab immediately for this patient? The answer should be no. I have to stop and clarify something here because I don't want you to misunderstand me. When I say do not activate the cath lab for a patient to send to go immediately to the cath lab, I don't really mean that you shouldn't really talk to cardiology, because sending the patient to the cath lab within less than 24 hours means any time between right now and 23 hours from now. So I would definitely discuss these patients with the cardiology team, and I will just go with their suggestions. If they advise sending the patient now to the cath lab, that is still within 24 hours. And if they say, let's hold fire, we're going to take the patient to CCU and then we're going to take the patient to the cath lab later, that's their own decision. But there is a big difference between accepting this decision, knowing that there is a scientific and a guideline background to this decision, and it is supported by the latest evidence, versus me just accepting without understanding. So for this patient, I will discuss with cardiology, and I will go with what they suggest, whether it is right now or within less than 24 hours, because there is no difference in the outcome. And now we're going to move on to our last case. So 69-year-old male patient presented to ED with a history of chest pain. And the pre-hospital team, they did an ECG when the patient had the chest pain, and the ECG showed a STEMI. They decided that they're going to go straight to the cath lab, but suddenly the pain improved. The patient became pain-free. They repeated the ECG, and the ECG showed no STEMI. So they brought the patient back to you in ED. So you've now got a patient who's had chest pain not long ago, and he's had a STEMI during that chest pain period. Then pain improved, no STEMI now. Would you immediately activate this patient? Would you immediately activate the cath lab for this patient? Yes or no? Would this patient qualify for immediate PCI activation in your local hospital? A few more seconds to get just more answers, and let's see. Okay, that's really interesting. So 2/3 of you believes that this patient would qualify for immediate PCI activation. Okay, very interesting. Let's explore this. Let's talk about PCI for transient ST elevation. So again, we're going to go back to the same guidelines that we've been talking about, the European Society of Cardiology guidelines published in 2021, talking about ACS management in patients without persistent ST elevation. And this is what they said. They basically said that patients with transient ST elevation, they found when they studied their heart using cardiac MRI that the infarct side didn't reduce. Going immediately for the cath lab didn't reduce the cardiac MRI infarct size. So based upon this, they decided that early invasive strategy within 24 hours is recommended for some patients. One of them is transient ST elevation. We are in green. This is the highest level of evidence. This is a +1 evidence here. So transient ST elevation, they go to the cath lab within 24 hours, not immediately. So if we go back to our case, so our 69-year-old male patient that presented to you with chest pain and a history of a STEMI when the pain was there, and then now you've got no pain, no STEMI. If I ask you if this patient would qualify for immediate PCI in your hospital, the answer should be no. But again, this is a patient that I will discuss with the cardiology team regarding cath lab activation, because simply they might decide to take the patient immediately for the cath lab. It's their decision. They know their priorities and they know they can triage their patients. But I will completely understand if they say this patient can wait and go to the cath lab within 24 hours. So our learning points from the 3 cases are: immediate PCI within less than 2 hours is recommended for patients with non-STEMI if with hemodynamic instability, with electrical instability, and if the chest pain is not responding to medical treatment. And I'm not just talking here about some aspirin GT, and I'm talking about maximal medical treatment. So we're talking about up to GT and infusion in my head. If you try all of these and you fail, then you should think about immediate PCI. While delayed PCI, so within less than 24 hours, that's recommended for patients with non-STEMI if they are post-cardiac arrest but stable, or if they've got transient ST elevation. So this is my email address. If anyone would like to communicate with me, I'll be more than happy with this. Please send me any interesting ECG cases that you have. And that's me done. Thank you very much. Happy to take any questions. Thank you.